We welcome you to the Global Health and Relief Initiative War and Recovery podcast series. On our episode today, we will be exploring the serious topic of human trafficking. My name is Bruce Dane. I am the Executive Director of GHRI, and let me introduce you to our own Dr. Nada Mukadam. She will introduce, in turn, our guest, Dr. Molly Gordon. Dr. Mukadam is a professor of psychiatry and behavioral health sciences at Baylor College of Medicine in Houston, Texas. I also have the pleasure of serving with Dr. Mukadam as a board member at GHRI. So, Nadal, why don't I let you take some time, introduce yourself if I missed anything, and introduce Dr. Gordon.
Thank you so much. I'm delighted to be here today and delighted to have Dr. Molly Gordon as our guest. Dr. Gordon is an associate professor of psychiatry at the Menninger Department of Psychiatry, Baylor College of Medicine in Houston, Texas as well. So I have the pleasure of knowing her personally. She is also the medical director of the anti-human trafficking program at Baylor and runs the inpatient psychiatric unit at Ben Taub Hospital. So she is a very, very accomplished woman who has chosen a difficult task of human trafficking as her career niche in this professional life. So
Thank you.
welcome, please, Dr. Molly Gordon, and we are thrilled to have you.
Thank you for having me. I'm excited to be here and talk about what I always love to talk about, which is human trafficking, why it happens, and what we can do to mitigate this harm.
It sounds to me, just reading your titles, that you do a lot of things. You're also the co-founder of the Division of Global Mental Health.
Yes, I do a lot of things. I'm clinical faculty at Baylor College of Medicine, and it's from that patient cohort that we treat on a daily basis where the program actually developed. So we had a cohort of patients maybe in 2016, 2017, who reported to us that they had been victims of different types of trafficking, labor and sex trafficking. At the time, we thought we were brilliant because we had identified human trafficking on an inpatient psychiatric unit and wrote a case series around those 6 patients that we saw very early in our program. Since then, we have screened hundreds of almost 1,000 patients in the last few years and identified over 800 patients just from our unit in our hospital system. So what we thought we had found, we really did truly open Pandora's box of identifying trafficked persons in healthcare systems. So that's how we got started. And that's why we do the work we do, to serve the patients that aren't getting enough wraparound care.
And thank you for this introduction. I do think you are brilliant, and your team as well. You guys are very dedicated. So today we will be discussing human trafficking because a lot of people don't know what it is and have somewhat of an idea maybe, but lack a true understanding of the scope of the problem. Can you kind of outline for us what that is, human trafficking, and then the scope again? How many people do we think are currently entrapped? What goes on when somebody is trafficked, etc.?
Yeah, that's a great question. When this patient reported to us that she was being trafficked, my first thought was, well, that doesn't happen here in the United States. It's something that happens in other countries. So I didn't think it was something that was even possible, which shows my ignorance of the topic as a healthcare professional, even just in the last few years. And then when she was talking about her experience, I thought to myself, well, maybe she's referring to smuggling. And then I realized that she was born and raised in Houston. And I had confounded smuggling, which is a crime across a border, with trafficking, which is a crime against a person. And so when we think about human trafficking, we think about it as a crime against an individual, not against a nation state. And we think of it sort of most commonly through what we call the AMP model. So 3 things have to be present for a person to be trafficked. There has to be an action, there has to be a means, and there has to be a purpose. And this definition is in alignment with the United Nations Palermo Protocol and the Trafficking Victims Protection Act of the United States. And so to be a victim of trafficking, that act has to be the recruitment, harboring, transporting, provision, obtaining, patronizing, or soliciting of a person. And so that sounds like all this movement But that's actually not always the case. People can be trafficked or exploited by people in relationships, by family members. It's often by people that they know. It's very rarely a stranger. And so when we think about an act, what you're thinking about clinically is the relationship between a person with some sort of vulnerability and another person who wants to exploit them for financial gain or harm. And then one of three means has to be present for a person to be trafficked. So a person has to be forced or frauded or coerced into either an act of labor, sex, or debt bondage. Now, often, all three of those are present. Force is a physical injury or implies some level of physical harm towards someone. Sometimes it can be confinement, close monitoring. It can include sexual violence. The fraud, when we think about fraud, is a lie or a false promise or an unexplained or unexpected change between a vulnerable person and another. And then a coercion is a psychological manipulation or a lie, or a threat or a blackmail. But not uncommonly, people will fraud or lie to someone as well as coerce them. And often there's also physical injury. And so that definition holds true unless you're talking about a minor. So, for example, in the United States, commercial sex acts where a child engages in sex for something of value, like food or clothes or housing or transportation or money or drugs, and they engage in this behavior without necessarily a third-party trafficker, the commercial sexual exploitation of a child is, by federal definition, human trafficking. So you don't actually need force or fraud or coercion when you're talking about a minor under the age of 18 engaging sex or sex acts for something of value. And that's, I think, where the definition can be a little bit confusing. But on the other hand, it's one of the reasons we're able to get so many prosecutions, I think, for victims who are children, is because that threshold for proving force, fraud, and coercion is not there in the federal definition.
So MAP means is M?
So AMP. A is an action, M is a means, P is a purpose, although MAP would be easier to remember for sure. AMP, it's called an AMP model.
And what we're looking for is maybe a reason why this is happening? Or does it have to be a reason?
So usually there's a few reasons. A person is trafficked because they're in a vulnerable social state. So their needs are not being met. And so they may engage in developing a relationship with somebody that could exploit them, which is a higher risk of engagement for either their basic needs. Maybe it's a romantic relationship. Maybe it's a familial relationship. Someone is gaining something financially from this person. So it's forced sex or physical labor work, and then somebody's getting something from it, a buyer, a trafficker. But sometimes, but very rarely, the victim of trafficking gets some sort of benefit, meaning they may get housed, they may get food. They may not get financial gain from it, but usually somebody is.
Okay. And what is the scope? How many people do we think are currently entrapped in this kind of web?
That's a great question. So it depends on whose data you're looking at. Our best numbers come from the ILO, the International Labor Organization. When we first started in the space, the ILO data for global estimates of human trafficking, which includes labor trafficking, sex trafficking, and forced marriage, was around 40 million persons, and that's 2017 data. That number was recalculated in September of 2022, and that grew to over 50 million persons worldwide. Now, the question is that because trafficking is rising and on the rise, or is it because we're better at identifying trafficking? So keep in mind that the anti-trafficking space in the early 2000s, when the Palermo Protocol first started, was very focused on prevention, suppression, and punishment of human trafficking. And only recently, in the last 15 plus years, maybe 10 to 15 years, has there been this push to include a public health response to human trafficking. The best example I have in explaining it to someone who's an addiction psychiatrist would be, instead of treating patients who were using substances we would only arrest drug dealers. And so it does help to arrest drug dealers. So there needs to be a prosecution model when we're talking about harm towards others. But we can't ignore the individual who may be a victim of violence and have physical and psychological harm as a sequela of engaging in this work.
Right. Do people escape from this? Do we have any estimate about that?
So that's a good question too. So our estimates are probably underestimates. So that number I gave you is based on math models on who's at risk for trafficking. So it is a very elusive crime. There are a lot of barriers to identification from multiple parties involved. So, for example, the individual who's being trafficked may have engaged in activities that were illegal, or that where they were forced to engage in sex work, which in some countries is a crime. Or maybe they were forced to engage in some sort of criminality. And so they may hesitate to disclose their trafficking experience to authorities for fear of the legal consequences from that disclosure. There's a lot of shame that is associated with victims of trafficking, whether victims feel like it's their fault or that others would maybe be disgusted if they learned that they were trafficked or sold. So they may not disclose because of the privacy associated with knowing that information. They're afraid their friends or family or loved ones may know about it. There's barriers on the healthcare side. Doctors are busy clinically. And so when we identify a patient who's been trafficked, there's often a lot of medical and psychiatric and social need. And it demands a lot of time and energy. And there can be burnout associated with working with this patient population. In the state of Texas alone, there's an estimated 313,000 trafficked persons. That work comes from the University of Texas Institute for Domestic Violence with Dr. Noel Bush-Armendariz' work. And so to give you an idea about one small hospital in Houston, if we identify and recover, let's say, 1,000 patients in a decade, imagine doing that at every hospital in the state, or every hospital in the country, or every hospital globally. So, the other issue when it comes to recovery is return to their trafficking. A lot of times patients, like other forms of violence, including things like domestic violence, don't always leave the person who's perpetrating violence, even when they've been identified. And so part of the public health response is reducing the harm that comes from ongoing trafficking, even when they've been identified.
So this is an excellent segue to ask you, who is at risk for being trafficked? I know that in the media, or when people talk about trafficking, they talk often about sex trafficking because it's it's catchy, but the majority are actually labor trafficked.
And that's
So
correct.
who is this? Right. So who is at risk to be in that pot or that one?
It's a great question. So in the state of Texas, that 313,000 number, over 230,000 of those estimates are actually victims of labor trafficking. And so when we think about trafficking, our mind automatically jumps to young girls who are victims of sex trafficking.
Yeah.
But we know that globally, labor trafficking dominates the space. And there's risk at multiple levels. So if we think about who is going to become trafficked and why, we like to think about it in what we call a socio-ecological model of understanding risk. Gautham and Podell wrote a great paper in 2019 that looked at the risk of the individual in the context of their society. So maybe at the individual level, there is a gender or an age-related vulnerability. We know that globally, women are trafficked 2/3 of the time compared to men. They may just be trafficked for different things. Maybe they don't have citizenship or other ways of working in a safe manner. Maybe they're part of a migration community, and resources that are currently available, like education and jobs, are not because of conflict or migration. Maybe they are unmarried or don't know that they're being exploited. I can't tell you how many times we've taken care of patients and disclosed to them that they were being trafficked. And they similarly didn't believe that it was something that's what they would describe what was happening to them, whether it was because it was trafficking by a family member or intimate partner, or because it had been happening since their childhood and into adulthood, and it seemed like their norm. We also know that there's interpersonal risks. People who grow up with a lot of adverse childhood events, those are essentially bad things that can happen to a child in a home, where there's other forms of violence or family dysfunction within the household. Persons with who are impoverished with poor education, who may not have access to education. There may be community risks, like we talked about conflict, but maybe cultural vulnerabilities, where certain populations are marginalized, whether it's because of race or gender or sexual preference. We know that there has to be a demand in a community for trafficking to happen. And so there has to be a demand for labor and sex in a community. So often a more populous community is going to be an environment where there's exploitation. And then again, policies, whether there's policies that enforce the punishment and the prosecution of trafficking, or is there policies that protect these vulnerable populations?
So there are personal risks and systemic risks, is what you're saying?
Absolutely. There's a risk to the individual, but it's that individual in the context of their relationship and in their community and the policies that are set out to protect them.
And are there any geographic hotspots?
Also a great question. We know that trafficking has been reported across the globe. It is a worldwide phenomenon. In the United States, it's been reported in every state. If we think about prevalence per thousand, worldwide, it's about 5 per thousand. This comes from UNODC data. There are higher incidences. So, for example, Africa is about 7.5 per thousand. Asia and the Pacific is about 6 per thousand. But it often happens very often in Europe and Central Asia, which is a prevalence rate of about 4. And then in the Arab states, about 3 per thousand. And the Americas, about 2 per thousand. So on average, it's about 5 per thousand, but it's everywhere. So some areas more than others. But it definitely has a presence across all communities and systems.
Okay. This is kind of scary. So you're saying it's everywhere. We just have to understand the local climate that may enhance these experiences and let them go unpunished. How about drug use and reproductive rights? I know these are 2 separate questions. Start with whichever one you want.
Well, let's start. Well, since you're an addiction psychiatrist, we should start with substance use. So we know that from the clinical work we do and from the peer-reviewed literature that there are vulnerabilities among populations who are using substances, especially among populations who are using substances at young ages and have a substance use disorder. The demand for substances by an individual may put them in contact with people who buy and sell other things. So people who are buying and selling drugs may also buy and sell people. They may not be able to afford their substances, and so they may use substances and then be forced into labor or sex work as a way of paying their drug dealer or whoever they buy drugs from. Being under the influence of drugs and alcohol make people more susceptible to physical violence or psychological coercion. And so they may be exploited only during the times they're intoxicated. Maybe they don't have a substance use disorder and are trafficked for labor and sex, and they are given substances to perform better. So, for example, if they are working 12 to 15 hours a day on a farm and they're given stimulants to work longer hours or to stay awake for longer times. If they're being sold for sex, sometimes traffickers will give them sedative hypnotic drugs to encourage compliance or to have available for people to use when they're being sold. Some of our patients are sold 9 to 10 times a day. That's a lot of forced physical and sexual violence in a 24-hour period. And the substance use is a way of their coping with this extreme form of violence. We've seen patients who are using substances, and then the substances are withheld as a form of coercion. So the trafficker then forces them into a withdrawal state and makes them psychologically and psychiatrically and physically ill, and then will only return the opportunity of having access to drugs when they comply with labor or sex demands. And then we know that in patients who have been identified and recovered, that they can have psychological harm that's longstanding, as well as physical harm, pain syndromes, all sorts of psychiatric and physical injuries. And that substance use, if it wasn't happening during the time of exploitation or as a vulnerability to being exploited, may become a maladaptive way of managing that psychic and physical pain. And so patients may develop a substance use disorder, especially if they don't have access to other forms of psychiatric treatment. So we know that there's a lot of intersection between substance use as a vulnerability, as a coercive tactic, and as a maladaptive way of coping with both labor and sex trafficking.
So I'm hearing the vulnerability on an individual level because the conditions that make somebody a prey are the same conditions that predispose them to be susceptible to substance use. So neglect in the household, ACEs, violence, etc. And then they're under somebody's governance, essentially. And the substance use can then be started or maintained or perpetuated to perpetuate the human trafficking. Isn't this why we see a lot of human trafficking and substance use in conflict zones?
It's one of the reasons. We want to think about trying to control large populations of people. And intoxication makes people more likely at times to comply with social demands of others. It also may be quite frightening to be in a conflict zone. And so substance use may be a way of coping with it, or people may use substances if they're about to fight. And then again, have those same vulnerabilities. We know that in conflict zones, there's a lot of individual risk, but there's also a lot of sort of state collapse, that laws that meant to protect these populations dissolve. So things like police and prosecution and social order that's meant to get people to help and help them recover from use or exploitation are no longer there. If we think about a public health response to trafficking, and we're in the middle of a conflict zone, hospitals, clinicians, and workers are going to be focused on injury related to conflicts, which are often very high at the expense of maybe more chronic injuries or chronic conditions like substance use or physical harm that comes from exploitation or sexual violence. If you're in a conflict zone and there's forced displacement or lack of shelter, then that becomes a driving force for basic needs to be met. So if there's no safe home or access to food, that people may use substances to cope with that extreme stress, or they may engage in relationships with people that are going to exploit them for labor or sex to get those needs met. Same with those same socioeconomic risks like lack of jobs and education in conflict zones, where humanitarian need may be fragmented, and so other forms of social instability and family breakdown.
Just could talk about drugs. Oh, sorry, Bruce.
Oh, this sort of reminds me. We had this conference in Jordan, and we had a physician, a doctor, who was zooming in when they had enough bandwidth and when things were working in Palestine, and this doctor was so he was working in a conflict zone, and he was just trying to take care of the very basics, right? And I think that anything that wasn't a life-threatening injury was simply not going to be seen by his clinic, by the hospital. And I imagine that's the strain that you see. Like, listen, when you're trying to put tourniquets on arms, perhaps these go by the wayside. I do have another question. Oh, wait.
Well, I would say you probably see. I think about everything from COVID, which is an infectious disaster, to natural disasters, like in areas like Haiti or Syria, and then conflict zones. So when there are other public health needs that are more urgent then vulnerabilities like exploitation and sex trafficking and substance use become more subacute and may not be managed as frequently when resources are limited or when providers are not always as available.
And we have seen examples. Captagon in Syria, for example. Captagon has been used as payment forms for militias. We have seen opioids in Afghanistan. So there's been a lot. And these examples seem to repeat the same pattern, but it is not something that we can easily stop. We can kind of see it coming, a train crashing, but we cannot really fix it easily. I could talk about drugs for a very, very long time, but we should probably start talking about reproductive rights, unless Bruce has a question first.
No, I'll listen. I'm interested to hear.